this topic. But then when I went through I searched for what is latest in FSD. And what is given there is one of the thing that is glaring is most of the physicians, more than 80% of us, do not question this in our practice. And so mainly because we are not trained to do so. And secondly, we may be embarrassed or we are shy to ask these questions, which are very, very pertinent to the quality of a female patient who lives with diabetes. So, for an oversexed culture that isn't afraid to push boundaries on TV, movies, radio, and books and magazines, we are awfully shy about sex when it comes to our health. In fact, people with diabetes are at a higher risk for sexual problems. A study in diabetes care found that only about 50% of all and 90% of all women with diabetes have broached the topic with the doctor. So even the patients are shy. So, and the truth is, many doctors don't feel comfortable prodding. Oops. Sorry. Yeah, so the topic given to me is a myth for physicians and a nightmare for women living with diabetes. Based on the recent studies, as late as, as early 2025, female sexual dysfunction is a highly prevalent chronic complication of diabetes mellitus. It is high time that we take it as one of the chronic complications, which we don't really mention apart from the basic metabolic complications that we talk about. So affecting 20% to over 85% of women with diabetes, depending on the population type of diabetes and study methodology. So FSD in women with diabetes is not a myth anymore, and it is a significantly documented, frequently under-recognized, and a complex condition that acts as a significant nightmare for patients. The idea that FSD is a myth is essentially false. It is real and often debilitating complication of diabetes that requires proactive, holistic, and non-judgmental management from healthcare providers like us. So, coming to the background, there is a profound gap between clinical awareness and patient reality. While female sexual dysfunction is highly prevalent in the diabetic population, as high as 70 to 80%, it remains largely invisible in the examination room. So many physicians view FSD as a secondary or a non-medical issue due to inadequate training and conflicting diagnostic frameworks. So there is a knowledge gap. A 2024 study of 513 doctors revealed that 94.1% received no formal training in managing FSD. Only 11% routinely screened women for sexual dysfunction. So that's how sad it is. And coming to the diagnostic ambiguity, physicians often struggle with the proteus-like nature of symptoms that lack clear structural or biochemical explanations. Confusion is exacerbated by conflicting guidelines. So there are some guidelines like DSM-5 and ICD-11. I'll come to that a little later. And this is not a routine thing, guidelines that we are taught to ask our patients. So there is a definite clinical blind spot which we don't ask. The assumption is assumption is that many clinicians assume FSD is rare, low priority, or entirely psychogenic. And the reality is sexual health is a reliable marker of vascular and neurological integrity in our patients living with diabetes. The barrier is lack of time, training, and fear of patient embarrassment. So what is female sexual dysfunction? It's defined as a persistent or recurrent disturbance in one or more phases of sexual response cycle, that is desire, arousal and orgasm, or the presence of sexual pain that results in clinically significant personal distress. Professionally, it is a complex neurovascular phenomena influenced by a multifactorial interplay of biological, psychological, and sociocultural factors. Okay, so defining the spectrum of dysfunction in detail, so we come to desire disorders, which is otherwise known as hypoactive sexual desire disorder, HSDD, absence of fantasies or desire causing distress. So the number 2 is arousal disorders, which is inability to attain or maintain lubrication or swelling response, which is depicted in that picture. And then third one is orgasmic disorders, delay or absence of orgasm following normal excitement. And the fourth one is nothing but pain in disorders, which is otherwise known as dyspareunia. Coming to the prevalence, a nightmare in numbers. FST affects between 20 to 80% of women with diabetes, predominantly type 2 diabetes. In all the studies, what is mentioned is the type 2, it's about 70 to 80%, and type 1, it may be less than 20%, as low as 4 to 5% also. So, and then compared to approximately 40% in the general population at large. So, type 2 versus type 1, as I said there, then quality of life for these women is not just about physical symptoms. It significantly deteriorates the overall quality of life, leading to relationship strain, isolation, and reduced self-esteem. So, what is physician's myth? Why is it overlooked? The myth of low priority. Many clinicians prioritize hard medical targets like HbA1c and kidney function and many other diabetic complications which are known, but we overlook the sexual problems, and which is often viewed as a secondary or just a lifestyle issue. So gender bias in guidelines. Clinical guidelines historically emphasize erectile dysfunction in men, often omitting the similar recommendations on discussing about women. Lack of training and comfort. Up to 80% of diabetes healthcare professionals have not received the postgraduate education on reproductive and sexual health. We all know that. So this leads to double silence. That is 43% of providers are uneasy discussing the topic, and only about 19% of women are ever asked about this problem by the doctors. Coming to the pathophysiology, to debunk the idea of FST is all in the head, emphasize the biological mechanisms. So these are the mechanisms: vascular and nerve damage, and then neuropathy and psychological vicious cycle. I'll come to that in detail. Now, beyond lifestyle, impact on glycemic control and quality of life, we know sexual dysfunction increases the depressive symptoms of diabetes and burnout. That increase leads to depression and poor adherence to the glycemic control as well, which again in turn reduces the libido and motivation for self-care. So the metabolic cost, women with FST often present with higher HbA1c levels compared to the sexually functional peers. The organic basis, diabetic autonomic neuropathy. Sensory neuropathy, reduced vibration or thermal sensation raises the threshold for stimulation in women. And there is an autonomic neuropathy as well, we all know, impairs neurovascular response required for smooth muscle relaxation. And then key mediators are VIP, which is vasoactive intestinal polypeptide signaling disrupted by chronic hyperglycemia. So then the vicious cycle, the psychogenic overplay, we all know, physical pain or lubrication failure, which is organic, reduces the performance, anxiety and body image issues, and then avoidance of intimacy, relationship conflict and distress, and ultimately even the devices which are put on the women can interfere with their body image and spontaneity in their intimacy. So the organic basis 3, the endocrine and infectious ecosystem, is also a reason for the FST. The diabetic ecosystem creates a physical barrier to function through chronic inflammation and hormonal imbalances. So coming to the diagnostic criteria, as on 2026, for a formal diagnosis, most standards require that symptoms which persist at least for 6 months occur at least 75% of the time under DSM-5 criteria and cause personal distress if a woman experiences low desire but not bothered by it. It is not scientifically classified as a disorder. So how do we diagnose? DSM-5, as I was telling you earlier, DSM-5 is Diagnostic and Statistical Manual 5th edition, focuses on the overlap between desire and arousal, and it consolidates into 3 things, that is female sexual interest or arousal disorder, female orgasmic disorder, and genetic pelvic pain or penetration disorder. Whereas ICD-11, which is otherwise known as International Classification of Diseases 11th edition, maintains a more linear model separating dysfunctions into discrete categories, that is arousal dysfunction, orgasmic dysfunction, and sexual pain disorders, and hypoactive sexual desire disorders. So now a framework for intervention. Now knowing this is not enough, we need to know how to intervene. So interventions again are said as PLISSIT model, which starts from the bottom here. P for permission, validate the patient's concern. LI is limited information, and then SS is specific suggestions, and IT is intensive therapy. So 80% of our patients' concerns can be addressed in the bottom 2 layers in this picture pyramid. So first line management is non-pharmacological, as we do for all other diabetes management. So lifestyle, glycemic control, tight control prevents further neurovascular damage, and pelvic floor rehab, Kegel's exercise. I think most of us don't advise this. It helps even in stress incontinence, but Kegel's exercise helps in the sexual function as well, because it improves the blood flow. And then lubricants, use water-based for activity, moisturizers and maintenance, and device managements are also there. Device managements in the sense, if the patient is on a device during the sexual activity, it should be removed for some time. Now pharmacological options, referral pathways is pharmacotherapy is as mentioned here, then local estrogen therapy, especially for perimenopausal and postmenopausal women, and sex therapy, and when to refer for the intensive therapy is to refer her to the gynecologist for structural pain or refractory infections. Treating a woman, not just the glucose. Organic reality is FST is a marker of vascular and neuro health, and it is highly prevalent. The quality of life driver of mental health and adherence, and clinical action is to be taken by all of us. Ask the question, use the PLISSIT, and I would like to thank you for your patient hearing. I am not an expert on this topic. I hope I have done justice to the topic that is given to me.